So hello everyone, my name is Kate Nagel. I'd like to welcome you warmly to the second in our series of WHRTN webinars as part of the overall TAAHC program. So WHRTN stands for Women's Health Research and Translation Network. Oh, a little bit of interference here. It's part of TAAHC, as I said. TAAHC, as you will mostly all be aware, is a collaboration, or stands for the Tropical Australian Academic Health Centre. It's an NHMRC accredited centre, a collaboration between 5 hospitals and health services in northern Queensland, in addition to the Northern Queensland Primary Healthcare Network. I always say that, Primary Health Network, and QARC, the Queensland Aboriginal and Islander Health Council, as well as James Cook University, has 4 pillars, and we've just broadened those pillars a little bit to accommodate our interest in women doing women's health research. So before I get onto the housekeeping, I'd like to acknowledge the traditional owners of the land on which we're individually gathered. I'm speaking to you from the Wulgurukba and Bindal people's land, and I acknowledge their elders, past, present and emerging. So just a few housekeeping items. Please turn off your microphones and off your cameras during question time. Turn your cameras off during question. Anyway, okay. The microphones is important, just so we don't get feedback during the presentations. There's a Q&A session that is scheduled after each presentation, and again, after both presentations have included. So think of them as we have the 2 presentations. Feel free to put your questions in the chat box, and the wonderful Ray will no doubtedly remind me if that's the case, if there are ones there to look at, or use the raise hand function to ask any questions directly during our gaps. So today we've got 2 presenters, and first up is Sandra Downing, who's a valued colleague of mine from JCU Cairns. Sandra is a registered nurse and midwife and field epidemiologist with particular interests in public health, emergency humanitarian settings, women's and children's health in low resource settings, and sexual and reproductive health. And it's on that last topic that she's going to present today. So if I stop sharing, Sandra, you should be able to stop sharing, Kate. There you go. You're right. Perfect. Sandra, we can't hear you.
We have lost Sandra altogether.
Okay, that's no good.
Because the sharing worked at 5 to 1 and Sandra worked at 5 to 1, but we have lost her.
Okay, why don't we swing over to my presentation?
Yes, your slides weren't shared before, Kate, so we might just want to double check that.
Okay, let's try that. How's that?
Great. Just on screenshot now. Yes.
Just let me. One tick. How's that?
No, it's notes page.
Sorry, Kate, I got kicked out there, but I'm back now.
All right, let you go.
All right. So thank you for the opportunity to present here today. This is an unfunded body of work, and I'd really like to acknowledge the passion and commitment of the team who have made it happen. Now my mouse has disappeared. So, oh, that hasn't changed for you. I might have to just reshare my screen. Sorry about that. It's not liking. You always know when you test it 5 minutes before and it's fine, and then it goes pear-shaped. Okay. Right, now we're cooking with gas, I think. So, unintended pregnancy.
I do beg your pardon, Sandra. We still can't see your slides.
Oh my gosh. Okay, share. How's that?
I can see notes page.
We don't want that.
I can see your thing. If you go up to display settings on that. Oh yeah. That's it. Yeah. Try that one.
Yep. Have you got it right now?
No.
Yeah. All right, I'm going to stop sharing and then I'll reshare again like we did 5 minutes ago.
That it always happens to me when I've got 3 screens up.
Yeah.
Quite sure which one to go with.
Okay. So now I'm going to share you that screen.
That's perfect.
Wow, that took a bit of going. All right. So sorry, everyone. Unintended pregnancy is really an extremely common occurrence in women's reproductive lives. And we know that while there's a lack of national standardised data, there's been 2 relatively recent studies that found between 26 and 32% of all pregnancies are unintended. And while not all unintended pregnancies are unwanted, up to 30% will end in abortion. It's estimated that 1 in 4 Australian women will undergo an abortion in their lifetime. And of importance is that recent legal reform has seen abortion decriminalised in all jurisdictions, but there remains really inconsistent jurisdictional requirements and varying degrees of service provision. The Australian National Women's Health Strategy calls for an increase in access to sexual and reproductive health care information, diagnosis, treatment and services. But meeting this obligation requires a really adequately prepared workforce, particularly to provide unintended pregnancy prevention and care, which I'll refer to as UPPC. Nurses and midwives, who represent about 55% of all registered practitioners, are at the front line of our healthcare system, and they're really optimally positioned to provide UPPC, especially to marginalised groups. National bodies have been calling for urgent introduction of this content into healthcare curriculum. The Sphere Women's Sexual and Reproductive Health COVID-19 Coalition, which is a national group of sexual and reproductive health experts and stakeholders, has released a consensus statement calling for increased training in early medical abortion for all registered nurses and midwives to support task sharing models of care, and also for the provision of early medical abortion under appropriate policy and protocols. Additionally, there's been a call for undergrad education programs to include implant and intrauterine device insertion and removal within their curriculum to increase the number of skilled providers and improve access to long-acting reversible contraception. And more recently, the report of the National State Senate inquiry into reproductive healthcare, which was just released last month, makes recommendations about removing legislative barriers to nurses and midwives providing contraceptives and MS2-step, which is used for medical abortions, and also to review the sexual and reproductive health content in undergrad and postgrad training. And of note, they said that basic training on termination care and long-acting reversible contraceptions is currently insufficient in both nursing and midwifery undergraduate degrees. So this body of work started out a few years ago with just 4 of us, and we were galvanised into action after the November 2018 decriminalisation of abortion in Queensland. So much time and effort had gone into the campaign, and with no certainty of a positive outcome, little emphasis had been placed on workforce preparation. We felt initially that a review of textbook content would provide a really quick litmus test on undergrad nursing education around UPPC. So using our combined knowledge of curriculum, we identified subjects across our 3 Queensland universities, JCU, CQU and UQ, to identify subjects likely to include reproductive health, law and ethics. And then we accessed the textbooks used in them and had a look. So without going into a great deal of detail, we found that there was a really wide variation of information presented across the textbooks, with a particular lack of information around vulnerable population, patient education, and how to access services. We also identified within the text a range of really quite disturbing judgmental statements. The findings were presented at the 2019 Children by Choice Conference. From there, our little collaboration expanded to include another Queensland university and 3 more colleagues, and Dr. Joyce Capiello from the University of New Hampshire in the US. Joyce was a facilitator in the development of sexual and reproductive health competencies for nurses in the US. With ethical approval, we developed and implemented 2 national online surveys, one targeting nursing and midwifery faculty, and the other targeting nursing and midwifery students who were close to completion and also recent graduates. We also recruited a subset of the faculty for interviews. And I'm really pleased to say we now have the results from the faculty survey about to be published in the Collegian. The student survey paper is under review and the interview paper is close to submission. And in this presentation, I'd like to talk to you about the findings from phase 2, the 2 surveys. So our aim was to look at the perspectives of both the faculty and the student/recent graduates around what UPPC content they thought was included in the undergrad programs and what they believed should be included. And we also wanted to ask the current students and recent grads about their preparedness for practice and their exposure to UPPC in placements or clinical practice. These were descriptive cross-sectional online anonymous surveys. For survey 1, the nursing and midwifery faculty was open to academic faculty working in the delivery of nursing and midwifery entry to practice programs in Australian institutions. And they were eligible to participate regardless of the continuity of their appointment or the content area that they taught. Eligible survey participants for survey 2 were nursing and midwifery students nearing completion or within 2 years of graduation from Australian entry to practice programs. Participants were recruited using convenient sampling. We initiated contact with the 38 Australian institutions offering entry to practice programs through their nursing and midwifery department heads. Some institutions had internal processes and means of promoting the study, while others forwarded the invitation to appropriate staff at their discretion. The study was also promoted through a range of professional organisations and via social media. The study instrument was developed using the 27 essential nursing education competencies that Joyce had developed through a Delphi process in the US. These competencies are grouped under 4 key domains: attitudes, knowledge, skills counselling, and skills clinical. We added a 5th domain, public health, which included 2 knowledge-based competencies. Participants were asked to identify which competency statements they believed were taught in their program and what they believed should be taught in the program. The student grad survey also included questions around their preparedness for practice in 5 key clinical areas: pregnancy prevention, sexual history taking, pregnancy testing, option counselling and referral, and abortion care. The following slide provides a couple of examples of each competency statements for each of the 5 domains. And I'll just give you a minute there to have a look through that. So let's have a look at some of the results. 44 faculty members and 109 students and new grads responded to the surveys. Both sets of respondents were mostly female with similar levels of religious affiliation. Unsurprisingly, the faculty respondents were mostly older and the students were mostly younger. Faculty were from all states and territories except Tasmania, with the majority of respondents affiliated with institutions located down the East Coast, New South Wales, Victoria and Queensland. Students and new grads were from 14 institutions, with the vast majority of 64% of them from just 3, QUT, La Trobe and the University of Adelaide. 91% of respondents for the student survey indicated the main campus of their institution was in Queensland, Victoria and South Australia, so slightly different to our faculty. Interestingly, 95% of faculty participants agreed that nursing and midwifery students should be taught UPPC, and 93% of student survey respondents agreed that they should possess those skills and knowledge. So a really strong finding there. This next slide looks at the results for the attitudes, knowledge, and public health domains. So there was 14 competencies across these 3 domains. The 5 attitude type competencies related to applying ethical principles, identifying personal beliefs that could interfere with the provision of care, providing care that was free from bias and judgment, knowledge of professional responsibilities, and identifying unique reproductive health needs in vulnerable populations. Over 85% of respondents from both surveys agreed that all 5 attitude competencies should be a core requirement. However, fewer than 50% of respondents indicated that these competencies actually were taught. Over 70% of respondents from both surveys agreed that 5 of the 7 knowledge competencies should be core. These were competencies around anatomy and physiology, confidentiality regulations, contraception, prevention of unintended pregnancy, and laws related to minors' access to reproductive health care. The other 2 competencies related to knowledge of induced abortion types available in Australia and adoption options, resources and laws. Interestingly, 75% of students felt that knowledge of induced abortion should be core, compared to 61% of faculty. So there was quite a little bit of difference in their beliefs there. Knowledge of adoption was considered the least necessary for both groups of respondents. And again, apart from the competency related to anatomy and physiology, less than 50% of respondents indicated that these competencies were core requirements. Of the 2 public health competencies, faculty respondents felt strongly that knowledge of unintended pregnancy and abortion statistics and trends in Australia should be core, around 84% of them. However, students at 67% were less inclined to agree. Neither group felt strongly either way about knowledge of unintended pregnancy and abortion internationally. The counselling competency most likely to be considered as both should be and is taught was around effective communication skills that encompass respect for culture, sexual orientation and gender identity. This was followed by the competency on proficiency in promoting sexual health self-care practices. However, both of these competencies were identified by less than 60% of both respondent groups as currently being core. The competencies least likely to be considered as should be or are taught were around use of essential counselling techniques in provision of UPPC, provision of client-centred risk reduction specific to unintended pregnancy prevention, and providing pregnancy options counselling, including parenting, adoption and abortion. Across all 6 counselling competencies, respondents from the student survey were more likely to identify them as should be core than faculty respondents. The 3 clinical skills identified by most respondents in both groups as should be core were obtaining a complete health history, which includes sexual history, assessing for intimate partner violence, and referring clients with unintended pregnancy to area providers and support services. Of these 3 schools, only one, taking a health history, was identified as being taught by about 55% of both respondent groups. Again, across all 9 clinical competencies, respondents from the student survey were more likely to identify them as should be core than faculty respondents. Most students and new grad respondents felt somewhat or well prepared to provide women-centred pregnancy testing, so 76%. 66 agreed with, felt somewhat or well prepared for pregnancy prevention, and 57% for sexual history taking. But really few respondents felt this way about provision of options counselling and or referral at 23%, or pre or post-abortion care, just 13%. Just over half of respondents, 60%, felt unprepared or not very prepared regarding ethical and legal considerations around abortion. So, in conclusion, we found a really substantial disconnect between what faculty and student/recent graduates believed should be taught compared to what is taught. And these findings suggest that while respondents appreciate the importance of UPPC in undergrad ed, it's not prioritised within the curriculum. It was unsurprising, therefore, that competencies that are applicable across the curriculum tended to be more likely to be taught than more UPPC-specific content. Our findings are actually quite similar to that of studies in Japan and US, where faculty identified that UPPC was important but not sufficiently covered. Now, we recognise that our study has got a number of limitations that have to be considered when we interpret these results. Firstly, 9 of the 38 institutions did not promote our survey to staff or students, with 6 non-responding to emails and 3 declining to participate. Therefore, our results may not be generalisable. Secondly, there was a significant uncertainty about what was taught across curricula. It's possible we have underestimated the extent to which UPPC is taught. Thirdly, choosing to not ask faculty respondents to identify their institution was a deliberate strategy to encourage participation. However, it's limited the ability to discern how representative our sample was. And finally, 24 of the 44 faculty respondents indicated that they had clinical experience in providing UPPC, and it's quite possible that this experience may bias their responses towards believing content is worthy of inclusion into the criteria. However, we believe there are a range of drivers to support a conversation about and prioritisation of UPPC in curriculum. Many barriers for public provision of services have been removed with the decriminalisation of abortion in all jurisdictions. There's been a call for reorientation of nursing education towards primary care to better prepare graduates for practice outside of hospital settings in the Educating the Nurse of the Future report. The International Confederation of Midwives has an essential competency around provision of care to women with unintended or mistimed pregnancy. And the Senate report has made those recommendations around the need for inclusion into curriculum. So our group strongly believes that the workforce must now respond to ensure equitable UPPC access for all women. Nurses and midwives are so well placed to be leaders in the provision of this care, particularly in primary health care and community settings. But we need to have the conversation and prioritise this content to ensure that our nurses and midwives can practice to their full scope of practice in this area. Thank you.
Fantastic. Thank you very much, Sandra. That's a fabulous presentation. Has anyone got any questions? While you're thinking of your best questions, I might pose a few if I could. Really important work. And I note the, of course, as both of us being midwives know about that International Confederation of Midwives, including in the basic competencies, duration of pregnancy care. Did you have a look? I suppose the number is a bit small, but did you have a look at that subgroup of midwives and midwife academics, and as well as midwife students, to see if they were any different from the nursing students?
No, we haven't actually. That would be an interesting analysis to look at. I think it was interesting that both groups didn't feel that understanding or having knowledge of unintended pregnancy and abortion care internationally was important.
Yes.
Whereas when we think about the role of unsafe abortion and maternal mortality, which is one of the enormous killers, I found that somewhat surprising and a little bit disappointing. From the students' perspective, I could understand because they wouldn't know. But from midwifery faculty, I thought that was quite an interesting finding.
Yeah. As a global citizen, you'd imagine that they would have that. Okay, what's going to happen? What next?
What next? So we have we're in the middle of analysis of and writing up of the qualitative data from the interviews with the subset of the faculty, and that's looked at very much the barriers to inclusion in curriculum, and also some of the really innovative and creative ways that staff have incorporated it into curriculum. So we're hoping from that to be able to do some really nice presentations to key groups around how it actually could be included and what would need to happen to make that work.
I suppose it is so content heavy. It's finding what goes to be able to fit it in. Have you thought of having a talk to ANMAC about the findings?
Yes, absolutely, we have. We did present at the symposium of the Deans of Nursing and Midwifery. We presented last year or the year before to them of our preliminary findings. So I think we're a bit late for the one that's coming up, but we would certainly be pushing to present again at the next one and to provide a report into them. Yeah.
So just for non-nursing midwifery audience, that's the accrediting body of the curricula for nursing and midwives. That would be a good place to get a bit of traction going there.
Yes, it would.
Response rate. What was that?
Yeah, it was
hard to tell.
Hard to tell because there was no clear available data on the number of current students in those areas. And when you try to look at faculty, you've got so many who are casual contracts, and it was impossible to be able to ascertain. So we recognise that that's a limitation. We really don't know how generalisable our findings are, but I mean, gut feeling is that they probably are generalisable, but from an academic point of view, no.
Yeah, no, that's always particularly for national surveys, it's always a bit of a difficult thing.
Yeah.
No, well, that's fantastic. Any questions out there? Ray Thomas, please.
Hey, no, that was great, Sandra. I really liked, really interestingly thought out progression of studies, and Kate sort of asked some of mine, like accreditation and what are some of the barriers about implementing that into that. And I think that getting to that accreditation body would be a really interesting thing to do. Have you gone back? One of your first studies was having a look at teaching materials and textbooks in particular, and now you've gone and said, has it been taught? Is there, I mean, I'm sure textbooks vary depending on nursing schools and things like that. Are they too many to go and check whether or not some of these terms, keywords are embedded in the textbooks across the universities who responded? So what I'm thinking about is how accurate is it to say it's not taught by the students when they probably just forgot because it was in year one or something like that? How could you go about doing that, do you think? Or is it important? Might not be.
Well, when we looked at the textbooks, there are kind of core textbooks that most universities use. There's not great variation. So I'm not sure that it would be all that. And textbooks are just one resource. You know, it really was just to try to do a quick and dirty, really litmus test of what was out there. I don't think it would be a really useful thing to do if we were wanting to seriously delve into what was taught in curriculum, because textbooks are just one resource. But certainly some of them had some horrifically judgmental statements in there, things that were simply untrue. Things like, you know, the most likely person to have a termination of pregnancy is a young, you know, kind of disorganized, you know, young person. And I don't know, there were some other judgmental statements around, you know, that it's going to be a really life-defining, awful experience that will live with that woman forever, and they're going to need all this counselling and support. And research shows that that's not necessarily true either. So they were perpetuating myths, some of these textbooks, and they were still relatively recent textbooks. It's not like they were old ones. We were using the ones that are currently used.
Okay, there's thank you. I'm thinking course learning outcomes might be another way of looking at that.
Yeah, we did look at them, and there's nothing in there. Everything is so broad and generic now. Specific content is really not well defined.
We've got a posted question up here. Thanks, Sandra. Do you know what year of study the undergrad students who responded were in their degree? If you were redoing the study, would you want the uni faculty to be identified or not? So
yeah. So we asked just for students in their final year of study. So that's the first question. Yeah, look, it would be nice to know. We did ask students to identify their faculty, their university, but we kept that, didn't link it back to their survey responses. And we could have done the same with faculty. And I think in hindsight, I don't think it would have impacted on participation. So I think we could have asked that, and that would have been useful to know.
Terrific. Well, thank you very much, Sandra. It's a fabulous series of studies. Great work, and fabulous to hear from you about them. So
thank you.
I might just try and share my, actually, if you could stop sharing, that would be fabulous. You have, there we are.
Yep.
Okay. Now, video, let's have a look here. How's that looking, Ray? Oh, see, I don't like it when you say that.
Sorry. That's it.
Is it?
Yeah.
Excellent. Fabulous. All righty. This is me, and it's my delight to talk to you about this body of work that originated back 16 years ago when I was doing my PhD. The design and evaluation, development and evaluation of a decision aid for prenatal testing was my PhD, and my supervisor was Jane Halliday, one of them. So this body of work is progressing that into what was a hard copy booklet, and it's had iterations as web pages and whatnot, and now it's a web-based app. So I'm just going to present that to you and then provide you with the resource itself, which is a fantastic way of disseminating that information. So it's all about improving the communication of risk with women in pregnancy. That's sort of the focus of risk. What I'd like to do is look at the complexities of screening information, overview the prenatal testing for chromosomal abnormalities, present and apply a decision-making model that underpins the app, and then introduce and demonstrate a few pages of that app. So screening by any measure is difficult, and I think with her epidemiologist specialty, that Sandra would be better served than I probably to give this talk. But it provides a risk result, so it doesn't give a definite yes/no answer. Risk is always negatively framed, and so that creates a bias in and of itself. So if you give a risk of something happening of 1 in 100, and unless you say that means 99 out of 100 won't have the specific condition, whatever it is you're talking about. If you don't provide that balance, you're in fact giving biased information and prejudice towards testing and prejudice towards diagnostic testing as well. We do know that women compared to men have a lower numeric literacy. So that makes all of these results that are given in numeric form, it makes them more difficult to find, to understand. The screening metrics are often confusing. So not only is it a risk result, but it's also, they talk about sensitivity and specificity. They talk about positive, negative predictive value. They talk about residual risk. So all of these things are concepts that can, in a consultation, be spoken of without using, without adjustment for the woman or the couple's health literacy. So what is tested for and what is not is very important. Sometimes it's just assumed that that women know, and sometimes they're not even told. They're just presented as routine tests, which is still an issue today, which is disappointing. And then importantly, what the consequences of testing are need to be discussed. So all of this oftentimes on the first visit, when the amount of information women are provided with are is overwhelming. So over the years, in the last 20 years, the testing that's available has proliferated, and it's also moved earlier in pregnancy, which is a good thing. But it does mean it's moved from a situation where a woman would be given that information with their midwife or their obstetrician. It's moved into primary care with GPs providing that information. GPs' appointments are shorter than other appointments, and they're also, as I've said, given that with a whole lot of other information. There's an issue with the accessibility of the tests available, and that's particularly so when we're up here talking to you from Townsville. So it's a tertiary hospital, but there are people who attend this hospital who come from further away, and certainly more remote or rural and remote areas wouldn't have access to all the testing options that are available. The tests are specific. Well, they work specifically for specific gestations, and so that's important, because if a woman presents later in pregnancy, it means that some of those options won't be available to them. And there's also the value-laden decisions. So not only does the woman not have that information usually, but she doesn't. You can easily skew the information one way or the other, because you need to take into account her values. So just a few facts around the screening and testing issues. So screening tests, while it's a risk result, there's no physical risk to the woman or pregnancy. The diagnostic tests, the tests that give a definite yes/no answer, do have an additional risk of miscarriage. That risk is downgraded with better research and also better techniques. And so it is quite low, but this is additional to the risk of miscarriage that all women have. The information provided to the couple, is that of value? So that's essentially important thing to know, whether this information would be valuable, the results of the test, how much information does the woman want, and that varies enormously. What degree of certainty is important to the woman, or would that uncertainty make her anxious and affect her throughout pregnancy and affect her mental health? And what's the natural course of the decisions made? So about 2/3 of affected pregnancies affected with Down syndrome, will spontaneously abort prior to the end of pregnancy. So that's important for women to know as well. So this is just, next two slides, just two outlines of, actually this is taken from the decision aid itself. And down the green boxes there give you the characteristics or the results of the test. So that T21, that's Down syndrome, it's trisomy 21 detection rate. That is only a detection rate if women go on to have the diagnostic test. So that's a bit misleading, but you can see that the newer tests, the non-invasive tests, have a 99% detection rate if those tests that are identified at increased risk go on and have the diagnostic test. So you see across the banner there, that first row, you've got the combined first trimester screening test. That's an ultrasound and a blood test, a maternal blood test. The second trimester screening is just a blood test, maternal blood test. And then you've got the cell-free DNA test, which is a blood test, and the diagnostic tests are the invasive tests with the definite result. So this just gives you a look at what's Medicare rebate available. That's important for many women, and increasingly in this climate. What can be tested? So the tests, and so that T is trisomy. So there's Down syndrome, Edward syndrome, and fetal syndrome, as well as other conditions for the other tests. False positive rates, a test failure rate, so that means having to have the test again, but when the test is done, varies the type of test and the risk to pregnancy. So all of that. So this would be particularly suitable for someone who just wanted the summary information across and not be bothered with too much reading. So this is another way, I suppose, just highlighting the tests that are the conditions that are tested for in the different tests. So what underpins this model of this app is a model of informed decision making. So Teresa Marteau's model of 20 years or so in age, and it predicates that an informed decision is one that's based on correct knowledge, so a good amount of knowledge, uptake and attitude. So you can have an informed decision to have the test, or an informed decision not to have the test, and both are informed decisions. So looking here, informed intake is where the knowledge, with good knowledge, where the attitude to the results of the test would be valuable, and where the woman has the test. Of course, if the woman didn't have the test, we can think of reasons for that. With good knowledge, a positive attitude, but not having the test, it could be because it wasn't offered. It could be because she can't afford to have the test. It could be because the test isn't available. It could be because her partner or family mightn't have supported her choice, and that was influential. Whereas an informed decline, equally, this is considered an informed decision. It's based on good information, where the attitude is to the test is viewed as is negative, and the woman doesn't have the test. So equally, if a woman in this situation, where she's got good knowledge and with a negative attitude to the results from the test, if that woman we'd be concerned if a woman had the test, would that being the case? But you could think of the influence of partner or family, or a health professional. It could be what ends her up with information that's not valuable to her. So I find this useful in all sorts of healthcare. Actually, I find it just a useful model to work with. So just a brief introduction to decision aids for those of you that aren't familiar with them. They're used to supplement counselling provided by health professionals. So they're adjuvant resources. They are not meant to be standalone, but used in partnership with the woman or patient or client. They assist individuals to make explicit deliberative choices, particularly when the evidence can be equivocal as to one way or the other. They encourage the participant to take part in the decision, and as we know with all things in healthcare, the importance of involving the consumer in their healthcare is particularly important, and something that health facilities are assessed on now. Information on options and outcomes, on conditions, the probability of prior risk, and explicit values clarification episode are part of it. And there's a collective in Ottawa for the registration of all decision aids, and this decision aid is one of those that's registered with that body. So quite a bit went into the it was this development and evaluation originally. So we had focus groups with GPs and focus groups with women to inform the drafting. We had pre-testing of the different models that were developed, and we had buy-in from the local or the peak professional bodies, including and consumer bodies, including the Down Syndrome Association, and that was very informative with regard to wording. And then we evaluated the test in a resource that was the paper-based resource in a cluster randomised controlled trial in Victoria. So the changes that we've made since then were changes to the format. So now it's in app format. We've updated the statistics to reflect current information. We've updated the tests, particularly the non-invasive prenatal tests that are now available. And importantly, what was found with the RCT was about promoting numeric understanding and promoting informed decision-making. That decision, that values-based decision support is unchanged. So now let's hope, she says, that we'll be able to show you. So this is the website for the resource. Let's see. Here we go. Can you see that? Fantastic. So you can see, if I move you out of the way, yes, you can see up the top here, the home page, the decision aid. So that's values clarification, information on the conditions, information on the tests. And then what the women in the focus groups told us very clearly they wanted to know is what other women would do. So we included that in all versions. So you start the choice as a disclaimer there. What I should note, or should have noted, is that this is a collaborative project with Murdoch Children's Research Institute, where I did my PhD, and James Cook. So why use a decision aid? Ideally, women would use it pre-conception. Oh, come on, get out of the way. Okay. We don't seem to be progressing very far, do we? Let's go. Let's
down on disclaimer and tick a box.
Well, here are the stories. I think we could go that way, but no, it usually just starts. But it's not going to, is it? Okay, well, we can beat it at its own game. Oh, or not. Hang on. Okay, so this is just showing you some of the conditions that are available to be tested, including other rare conditions, and there is that difficulty with some of these newer tests giving rise to a lot of information that can't really be tested. So that's that table I showed you previously. So for women who want the bare amount of information, the summary tables are useful. For women who want more information, there's this is together with some resources at the back. Sorry, I'm having trouble with this. It does work. So this is more about the testing options that you can scroll through and learn more information if that's important to the woman. The stories we made sure that they were balanced with women choosing different options and including not having testing, making that decision, as well as different results, different consequences of the testing. I really would like to show you the questions, but I don't think I'm, oh yes, hang on, continue. There we go, that's what we wanted. Ray, you were quite right. Only seeing half of it. So are you pregnant? Yes or no? Let's say yes. How many weeks? And this will then direct you to the gestation limiting options that are available depending on that. So takes you through these different steps, gives information, and then poses these values clarification questions for people to respond to. At the end, I might just do this very quickly and doing just random things. Not really random, I'm doing the first option. Detection rate, so that's giving you more information. Have you thought what happens? Yep. Next, whoops. And there we are. So this gives the information to the woman that she's able to print out and take with her to her next appointment. So she's leaning towards testing, and there's a few more questions here. All relating to values, and then this tells her the type of test that she would like to have, or if she's unsure. So again, print that out, or just do this with her partner, and then take that to the GP for the next visit. So there we are. That is it. You have the web, we have that available. Please give that to any GP friends, midwifery friends, and relatives as well. Any questions?
Kate, I certainly have a question. I'm just interested to know how widely used it is. Like, is it something that's promoted through hospital antenatal classes and other kind of places where you might get a group?
Yeah, so it was launched in at the end of last year. The original version was disseminated by RANZCOG, by the PO&G College, National College, and was also in Kaz Cook's Up the Duff book. So so that was good. Because it was paper-based, so that was a lot of work, because as you know, oftentimes you do the evaluation, you do everything, it's fantastic, but then you finish your PhD, and it was a great success that RANZCOG took it up. But that did mean it was available just to women who were privately, women who were privately insured. And so then we went to the website, which was very well used through MCRI. And this time we're sort of getting it out slowly. So we're doing it through PHN, so for the primary health networks. We're doing it, I'm doing it at any conference I sort of speak at, just to promote it. We haven't gone back to RANZCOG, but Kaz Cook has agreed to undertake, and I've got another few people who've got popular textbooks that they're going to have it in. Part of the arrangement with the funding for this was that MCRI would host it, so they'd pay those costs and keep it up to date. So that's a great reassurance for these sort of, not that there is changes afoot, as you'd know, with prenatal testing, but they won't come in for a little while. We do need to capture them when they do.
That's great. Thank you.
Kate, online, we've been asked about, do you know if there are any plans to use it at Townsville Uni Hospital? And it's great work.
Thank you. Yes, absolutely available to everyone. I think the one issue with regard to getting into hospitals is women oftentimes don't present until about 16 weeks. So those first trimester options are not available, and they're the options that really create complexity with the amount of information that can't really be interpreted in a lot of those non-invasive test. So yes, available to anyone to use. To do it formally, I haven't actually thought of making it available formally. That's probably a good idea, maybe through the clinic. But certainly, the obstetricians have all been made aware of it, so that's good.
I have a question. First of all, I love it. I haven't seen the informed decision-making matrix used by people that I don't collaborate with. So it's like, yay, how cool is that? And I really like the way that you've embedded it into the decision aid. right? Because I don't often see decision aids that embedded a tool that asks whether or not people want that information. So it's a really nice way to, I love the continuum. It's like, oh, you're leaning towards this, or this really isn't for you because you said you don't want to do anything about it. You said you're not interested, so we should stop now. But I really super like that idea. One of my questions is, I hear you've gone to PHNs. This is my clinical naivety. And I'm wondering what about the RACGP network? Is that within something that you could look at? For
yes, absolutely could. It's absolutely could. I think we're doing just sort of the feed through MCRI and myself, but we should give it a bit more of a boost to get it out there. I think the website was quite well used, so we're hoping that there's already sort of a groundswell of people who are clinicians mainly, but hopefully women going directly there, which is also possible, also to be promoted. So yes, it does need a bit more campaigning. We've done it, through the processes of the GPs who were originally involved in their practices in the decision aid. There was 52 of them in Victoria, so we've got a sort of a strong hold there, which is great. But it needs to get out. Yeah,
because there's a prevention, the Red Book for RACGP. I wonder if that's around when it's getting updated. I can't really recall if that's being updated again. Love it. Stephanie and Elizabeth congratulated you and really liked the work, both of the presentations. In case you haven't seen the chat.
Thank you very much. Well, I think we can bring this to a close, and just thanking Sandra again for her participation. That's fabulous. Keep your eyes open for TAAHC activities. Jump on that website, and as Ray mightn't have said actually to everyone, is these sessions are recorded, and so if you've missed ones in the past, they are on a YouTube channel, and also pop follow WHRTN as well, because funding opportunities as well as events forthcoming will be advertised there, and we're developing that education and training sort of hub, curating that for everybody. Well, I suppose it's specifically for early and mid-career researchers, but open to everyone. It's specific to women's researchers in doing women's health research, but open to everyone. So that's it. See you next month.
Thanks, Kate. Thanks, Sandra.
Thanks, Kate. Thanks, Ray.
Thanks, Ray.